Okay.
Maybe they're called.
We're out of budget here.
For the.
All right, so Dr. Antich asked me to give updates in head and neck tumors, because you guys have seen some kind of interesting ones over the last year on FNA that are becoming sort of molecularly defined, right? So there are these morphologic overlaps, but now with molecular diagnostics being so prominent, a lot of these issues or entities can be sort of teased out. And so
Alright.
hello, hey guys. My goal is to tell you about the different the anatomic compartments of the head and neck, broad strokes, what are some big kind of either well-established transition, sort of new or emerging entities that are either defined based on morphology and or molecular or both. So in case you see this genetic fusion in your results, you'll sort of understand what it means and how we can deal with it. So the compartments we've been talking about are sinonasal, salivary, thyroid, and I don't know if I got the parathyroid. We'll see if we have time for parathyroid at the end. So my concept is, right, what are new entities? They're sort of usually tumors that have some kind of morphologic overlap with something that is known, but oops, all of a sudden we found this group that has a unique molecular driver or a somewhat slightly different morphology and or a somewhat slightly different clinical behavior, right? So like, is it a cat or is it a lion or is it some kind of feline that we can like bifurcate into a cat or a lion? And so we'll start with sinonasal tumors because this is probably the area that has undergone the biggest change in the last, 5 to 10 years. And so previously, when I was training, everything was snuck. Everything was just a high-grade sinonasal undifferentiated carcinoma if it wasn't like squamous. But now we have all kind of a lot of different known entities, some of which are truly carcinomas and some of which are mimics. And so I'm gonna start with the chart and then we'll go over some of these entities in more detail. But I think the chart is helpful to sort of understand how we can break down these high-grade, like epithelioid or blue cell sinonasal tumors. And so many of them are strongly keratin expressing and just end up being some variation of a carcinoma, which we'll talk about. Some of them end up being zero keratin expressing, but expression of melanocytic markers fine. Those are sinonasal melanoma. Then there are these other kind of entities that sort of straddle the epithelial versus not epithelial line. And we'll spend a couple moments discussing them. So one on the bottom here is Ewing sarcoma. So in the head and neck, there are these so-called adamantinoma-like Ewing sarcomas that look like carcinoma because they're kind of cohesive. They have keratin expression, so they mimic carcinomas, but they have strong CD99, Fly1 or ERG, and have EWSR Fly1 gene rearrangements, are now thought to be basically keratin expressing Ewing sarcomas. And this is quite specific, I believe. I don't know if we're seeing them in other anatomic areas, but we see it in the head and neck. We see it in the sinus. We see it in the sort of thyroid and neck and salivary area. So that's adamantinoma-like Ewing. Then there's like the neuroendocrine ones. So when we have a classic neuroendocrine carcinoma, right, that's just keratin expressing and neuroendocrine cell expressing, and it's got high-grade cytology, maybe it's small cell, maybe it's large cell, whatever, neuroendocrine carcinoma, fine. But then there are these other entities that look like olfactory neuroblastomas, right, where they're more low-grade, they have neuropil, they have rosettes. In your olfactory neuroblastoma sort of morphologic realm, but some of them express keratin, and then some of them express keratin really, really strongly. So is there but they're morphologically olfactory, right? So now there's this emerging entity of olfactory carcinoma that kind of walks the line between a classic neuroendocrine carcinoma, small cell, large cell, and a classic olfactory neuroblastoma that's just keratin dead negative, right? So this is kind of an emerging area to be determined what's happening. All these others up here are various types of carcinomas, right, that are either showing squamous differentiation by morphology or IHC or not, right? And so the ones that are not showing squamous differentiation usually by morphology or IHC are the so-called SNUCs and the INI or BRG1, the SWE/SNF deficient carcinomas. That I'll show you more slides of in a minute. It's this bucket here. So maybe focally, but not diffusely. Then there's nut carcinoma. So the word midline was removed from the name because it's not just present in the midline, but many of them are present in the head and neck and thorax of young patients. They kind of look squamoid with abrupt keratinization, but they're defined by nut BRD fusions, and the prognosis is extremely bad. Then there are these HPV-related carcinomas of the head and neck that are thought to resemble adenoid cystic, but they're strongly P16 positive, and they are specifically HPV type 33, not HPV type 16, right, which is what we see in the tonsils. And I'll show you a picture of these in a minute. Then there's this so-called DECAF carcinoma that's literally named with its gene fusion. So these are thought to mimic sinonasal or Schneiderian papillomas because of their papillary architecture, with their keratin and P63, P40, but have a little bit more high-grade cytology and specifically have this DECAF fusion. And then we're down to just our classic nasopharyngeal carcinoma that's EBV positive that we see more often in the nasopharynx, right? But this is kind of how I like to think about and structure looking at a sinonasal fusion, because you have stains that you can throw on to differentiate a lot of these. The last one up at the very top, SNUC, right, which used to be a wastebasket. Now we are finding that if it fits none of these other categories, right, it might have an IDH2 mutation, and it's probably now this is SNUC, right? So now these carcinomas with IDH2 gene mutations are kind of the leftover SNUCs, whereas everything else has come to an end. So here's what they look like. So nut carcinoma looks like a very primitive, monotonous, fusion-associated tumor, right? So when we say fusion tumors, they are generally very monotonous, whether they be epithelioid or round-celled or spindle, but they tend to have a look, right, that is very monotonous. And specifically, nuts have this abrupt keratinization or abrupt squamous differentiation that is sort of classic textbook. They sometimes stain with squamous markers, not even in this part, but also in the background part. And they have nut expression in the nucleus and nut fusion. Who knows what nut stands for?
Nuclear testes.
Nuclear expression in testis, exactly. So nut is expressed in testicular germ cells and in this speckled fashion in this carcinoma. That's pretty much it. So it's highly specific, really poor survival. These, as I said, these patients have the ability to enter into clinical trials for these BET or bromodomain inhibitors. They basically inhibit the BRD, and some patients end up having extra lifespan with this with these BET inhibitors. The INI1 and the BRG1 sinonasal deficient carcinomas, the SWE/SNF complex, can look a number of ways. They can look like these large kind of basaloid sheets, or they can look like these individual nests and strands, but specifically they often contain rhabdoid cells in any one of these variations. So just like all of the other SWE/SNF tumors, rhabdoid, right? So when you see rhabdoid, it's either a plasma cell, a rhabdomyoblast, or a SWE/SNF, right? So those are the three things that we want to think about. These can also stain kind of squamoid, and by genetics have SMARC losses. They tend to be highly aggressive also. Maybe not quite as bad as nut, but generally all of the INI BRG tumors are really bad. This one, on the other hand, is good prognosis. So if we can diagnose HPV sinonasal cancer, just like in the oropharynx, this is good prognosis. But you can see how it got its original name, adenoid cystic-like, because in a lot of areas it has this cribriform architecture, but not always, right? Sometimes it's solid, sometimes it's sheet-like. So throw your P16 on and your HPV RNA-ish. Our HPV RNA-ish that covers all 18 high-risk subtypes will pick up 33, right? So if you're not sure what it is, throw on your nut, right? Throw on your INI-BRG, throw on your P16 and HPV-ish, and you might be able to give the patient a better prognosis. Adamantinoma like Ewing's, you can see how it also has kind of this blue basaloid nested with peripheral palisading and these central little eosinophilic globules, right? These are all kind of starting to look like a little bit alike, which is why we need the stains. In this case, CD99 diffusely strongly positive, and EWFR flying one gene rearrangement. And these get treated completely differently, right? These get treated with Ewing's sarcoma type of regimens. And then DECAF. So these come in on low power, kind of looking very papillomatous, right, with both exophytic and endophytic growth. Again, kind of this hybrid growth pattern, but they're a little bit they're very blue. They don't have that Schneiderian epithelium. They don't have the little microcysts in the epithelium, and they have DECAF fusion. You guys just had one of these that it was interestingly a DECAF carcinoma that we didn't know was a DECAF carcinoma because it started in the lacrimal gland. And so we called it I don't remember what we called it, squamous papillary, whatever. It metastasized to the neck, right? Or the pericarotid or something.
The outside came and it was resection of the lacrimal gland
Right.
and the area.
Right,
Then it was
recurrent somewhere here.
recurrent in a parotid region,
Yeah.
preauricular region.
Right.
It was called again squamous.
Right. And then
And
you
then-
guys did some
and then-
molecular.
And then I got a second time FNA,
Mhm.
and it looked really kind of funny.
Yeah,
And I submitted for molecular, and this came
right,
as a
Right.
diagnosis.
Right.
I mean, as
as a fusion. Yeah, so you have this high-grade weird carcinoma somewhere in the pericarotid region, and it has DECAF fusion. Turns out it was a metastasis from this lacrimal carcinoma. So I don't know that DECAF has been described in lacrimal area, but apparently it can exist. Sinonasal papillomas can exist in all of these areas, so certainly why can't this? So it's good to know, right, what the significance of these fusions are because they can pop up in other parts. When we get to the salivary gland, we're going to talk more about this, right? But in your parotid specifically, this is anatomically a lymph node rich region, and it can receive drainage from anywhere in the head and neck, from the skin, right, from the ears, from the mucosal sites, from the eyes, right? So anything that's lymphatically draining down to the thoracic duct, right, can drain through the parotid. So you can pop up with metastases in this region, like left and right. So just something to remember. Okay, so that's my tangent from DECAF.
I have to say that
Yeah.
I reviewed this first FNA.
Mhm.
That was called squamous cell carcinoma, and it did look like squamous cell carcinoma. It
Yeah.
even had a little bit of
Yeah.
keratinization. Therefore, unless something really weird happens, or you think something
Yeah.
is weird in morphology,
Right.
it's really hard to
Totally.
figure it out. Yeah.
Totally. So it's like either you have to have a high index of suspicion, like something is off, or like it should sequence everything. But usually it's the ones that like are not overtly keratinizing, right? Like if there's some subtle keratinization, then it can enter into one of these differentials. The sinonasal adenocarcinomas have also been around for a while. They're sort of the generic non-intestinal CK7 positive type. There's the intestinal type, which CK20 and CDX2 positive, I think also SATP2, but looks like colon cancer, stain like colon cancer. The boards like to ask about this because it has a very specific occupational association with carcinogenic inhaled dusts, like wood and leather dusts. And now there's this entity of sinonasal renal cell-like adenocarcinoma. So we've got something that looks like colon and something that looks like kidney, always originating in the sinuses. Interestingly, this is negative for PAX8. So that's how one might distinguish it from a true metastatic RCC, because it can be positive for things like CA9, et cetera. So just to note that there is a primary sinonasal RCC-like tumor, but always excluding metastases from the other anatomic primary sites by clinical, and in this case, by IHC.
Is there anything molecularly?
Not that we know of, no, just generic P53s and things like that. You can get also any salivary type tumor originating in the sinus also, right? But we'll get to salivary later. All right, spindle cell tumors of the sinus are also not completely uncommon. So we have the classic solitary fibrous tumor, right? That's related to STAT6 fusion. So you've got STAT6 and CD34. We have the glomangioparasitoma, which is one of the perivascular myeloid neoplasms, right? So myeloid, it has SMA, and it's related to beta-catenin mutation, so it has beta-catenin in nucleus, tends to have more hyalinized blood vessels as opposed to these like thin-walled ectatic ones. And then biphenotypic sinonasal sarcoma, biphenotypic because it stains with hybrid SMA and S100 in different anatomic areas, like next to each other, and it has PAX3 mammal3 fusion, and sometimes the PAX antibodies can overlap, and you can actually get expression of PAX8, which we have, right? We don't really have PAX3 IHC. Interestingly, some but not all of these have this proliferative respiratory type epithelium that is entrapped with the tumor that's potentially not neoplastic, but is sort of enhanced by the presence of the sinonasal sarcoma. All of these are not of extremely high risk for metastasis, but risk for recurrence, right? So these are locally aggressive and locally recurring, rather than they're necessarily going to kill you like those other high-grade brown cell, blue cell tumors will. Make sense? Okay. So that was sinus. Questions on sinus?
What is your recommendation for the best immuno
Panel.
panel?
So if you're dealing with a spindle cell tumor,
No,
it's
just-
gonna be these. If you're dealing with the epithelioid tumor, it's gonna be like just a generic keratin, like an 81, 83, and a P40. To me, P40 is much more specific than P63, so I prefer P40. And then if you know you're in an epithelial world, depending on morphology, you can do a CD99 to exclude Ewing's. You can do the INI-BRG. You can do the P16. And depending on where you are in the nasopharynx, you can consider the EBV, right? And if you're then at a loss, we don't have NUT, so we have to send out for NUT. There's no we don't have the IHC for this, so you have to do fusion, right? So that would be sort of step 2. If the CD99, INI-BRG, P16, for example, and NUT all turned out, negative. So I kind of do it in a stepwise fashion. I exclude the ones that we have the IHCs for, unless the morphology is like super suggestive of something that we don't have, then I'll divert to like molecular or something, right? But usually it's this side of the stuff on this column. So I think this chart is really, really helpful because it can kind of direct you into what kind of stains to order. Okay, salivary gland. So we get salivary FNAs, right? We get salivary core biopsies, and we certainly get salivary resections. And so we, of course, want to determine that it is actually neoplastic. But as I said earlier, especially in the parotid, remember that you can get metastases through the parotid region. We've seen it all. We've seen metastases of cutaneous squames, metastases of cutaneous BCCs, metastases of melanoma. The one I forgot on here is Merkel. And any and all of DECAF, right? Any and all of these can metastasize to parotid region. So always have that in the back of your mind. However, mostly we're dealing with primary salivary in either sort of parotid or mandibular region. But again, any anatomic site that has salivary tissue, tracheobronchial tree, for example, right, can have salivary type tumors. All the way from the sinus, all the way down through the lungs can develop salivary type tumors. So on biopsy, we've come up with this algorithm, at least here, where we have decided if it's something low grade or something overtly benign, right? We sort of call it low grade or benign. And what they will generally do is resect and clean margin. If it's overtly high grade malignancy, we'll call it high grade malignancy, they will do a larger resection and they will do neck dissection. However, if it's this quote unquote basaloid category, right, which is cellular, very blue, overlapping differential, could be a cellular pleomorphic adenoma, could be a basal cell adenoma, basal cell adenocarcinoma, could be adenoid cystic, could even be something like epithelial myoepithelial carcinoma that's very cellular. The critical decision-making point clinically is if it's adenoid cystic. Adenoid cystic, even though it's morphologically somewhat bland, is very biologically aggressive. It invades nerves, it invades blood vessels, it travels, it tracks, so they're gonna do a wider excision, and they will likely also do a neck dissection if we call it adenoid cystic, regardless of the, classic morphologic grade, because grade in adenoid cystic is not very good at predicting or relevant. Okay, so if we have a basaloid neoplasm, we've decided that we're gonna do molecular testing to see if there's the MIB fusion that would be definitional of adenoid cystic. Sometimes we've had it pop up with a PLAG fusion. Turns out it's a PA, right? And sometimes we've had it pop up with a MIB fusion. Turns out it's an adenoid cystic. If you do not find a fusion, right, then you're potentially dealing with another one of the subtypes of tumors that are fusion negative that have some kind of driver mutation, right? We'll talk about this in a minute. Well, actually, let me go there now, right? So your neoplasms of salivary gland, almost 100% of them now have known drivers, right? So this is a chart of your sort of biphasic neoplasms, and this is a chart of your monophasic neoplasms. We'll get there in a second, but you can see how, depending on which tumor you are, you're either gonna have some kind of fusion or some kind of mutation that will pop up on our like DNA or RNA oncoplus. And so this can be very helpful to know where these sort. But in the absence of known genetics, right, because we are probably some of these first people to be doing molecular on FNA or core biopsy, right? Most people aren't. So this is what we've come up with as our internal protocol, but this doesn't mean it's happening everywhere. But our internal physicians have found that this differential diagnosis is important, and so we're doing this for them on FNA. But I expect maybe in the future it'll be a little bit more common. So when we don't know the genetics, but we have like a cell block or a core biopsy, I tend to start for salivary glands with 3 stains, right? The 3 stains are P40 and CD117 or c-KIT, right? Because P40 is gonna be present in your myoepithelial or your abluminal or your basal cell population, whereas c-KIT or CD117 is gonna be positive in your luminal or epithelial cell population. And S100 is variable, but we'll see in a minute how it comes into play. It could either be positive in your myoepithelial cells, or if it's a monophasic tumor, it can be diffusely strongly positive in some of your monophasic tumors. So those 3 together will pick up a significant percentage of your salivary neoplasms. So those are the 3 stains I'd start with. All of these here are in the biphasic category, right? Biphasic tumors include pleomorphic adenoma. How might we suggest more of a PA? Maybe it's got some cartilage in it. Basal cell adenoma, basal cell adenocarcinoma is also biphasic. This tends to have tubulotrabecular morphology and diffusely strongly S100 positive spindle cells in the stroma. Don't worry, we're gonna see these. Adenoid cystic carcinoma, does it have that classic cribriform pattern? Does it have wrinkly dark nuclei? Does it have perineural invasion? Right. Epithelial myoepithelial carcinoma tends to be very lobulated, tends to have morphologically clear cytoplasm in the myoepithelial cells. And sclerosing microcystic is much rarer, but it is also technically biphasic, but as its name suggests, it's highly stromal, right? Very sclerosing in the background of these bilayered ducts. So these are your biphasic tumors, with a little bit of an exception, as we'll see in a minute. So when you've thrown your 3 stains on, right, and you come to a P40 completely negative population, right, then you're dealing with one of the monophasic salivary tumors. If you have a P40 diffusely positive population, then you're maybe dealing with something like potentially a myoepithelial carcinoma, a hyalinizing clear cell, or a pure mucoepidermal carcinoma, with the exception of there also being present of mucocytes, right? So this is gonna be in your diffusely strongly P40 positive population, you're on the right-hand side. In the dead P40 negative, you're on the left. And many of your dead P40 negatives are gonna be S100 diffuse positive. In this case, the c-KIT is less important because it can be patchy and kind of nondescript. But in this case, the c-KIT is very relevant because it's specifically present in that luminal cell population, okay? So in this case, P40 and c-KIT are important, and in this case, P40 and S100 are important. Your S100 diffuse strong positive monophasic tumors include things like canalicular adenomas, which are more specifically like on the lips of elderly females, microsecretory carcinoma, which is quite rare, polymorphous and cribiform, which tend to be present in your minor salivary glands, secretory carcinoma, which also is positive for mammoglobin, and intraductal carcinoma, which also is positive for mammoglobin. And this is one of the ones that we just came across, some of you know, where we had an FNA of a carcinoma that was P40 negative, S100 positive, and mammoglobin positive, and it was fragmented in an FNA, right? And we looked at it and it looked like, and it was called secretory. However, as we'll see in a minute, when it was resected and when molecular was performed, it came up with a fusion that was specific for intraductal, and it actually ended up having P40 positive cells, right, present only at the periphery of the tumor, which basically defines intraductal, which I'll show you in a minute. So this is kind of at the edge of the monophasic, kind of creeping into the biphasic. But pause in your brain for a moment because I'll show you the morphology of this later. But for the most part, most of these tumors can be sorted out based on these three few stains. What other branch have we not hit? Your P40 negative, but S100 negative, mostly you're dealing with only acinics usually. I will say one caveat on myoepithelial carcinomas. We don't think that there are pure benign myoepitheliomas of salivary glands. They are usually either pleomorphic adenomas that are duct poor, that occasionally, very rarely, you'll find a duct, right? Or they are myoepithelial carcinomas that are deceptively morphologically bland. The problem with neoplastic myoepithelial cells is that they can express any or few or all of the myoepithelial specific markers. So I like to think of the myoepithelial specific markers in kind of a few different buckets, right? One is the P63, P40, like basaloid keratin, high molecular weight keratin bucket, right? One is the like S100 SOX10 neural crest bucket. And one is the contractile, like myogenic bucket, like SMA calponin, right? So you need some of those or one of those in a myoepithelial cell, but you never know which one you're going to get, right? So you sort of use a panel. So you use your S100, your SOX10, you use your P63, P40, and you use your SMA calponin across the board to determine if a cell is potentially of myoepithelial differentiation, right? These two, the HCCC and the mucoepidermoid, only have the P40, the P63. They do not have the neural crest S100, the SOX10, and they do not have the contractile SMA calponin, okay? So they stain kind of like squamous, right? They don't have those added other buckets. Does that make sense? Okay. Mucoep, of course, has the added bucket of mucinous cells. Now that I've bored you with my algorithm. Oh, the last algorithm is oncocytic. This is not quite as unique because there are only a few oncocytic entities. Things like oncocytoma, Warthin tumor, or Warthin-like mucoep, and then maybe some oncocytic salivary duct carcinomas. The interesting thing about the oncocytic tumors is that even though they are morphologically monotypic, right, the oncocytomas and the Warthin tumors are morphologically only oncocytes. If you throw a P40 on them, the abluminal or the peripheral or the peristromal oncocytes will be P40 positive, and the rest won't. So even though they look exactly the same, you can pick them out on IHC, just for curiosity. Warthin-like mucoep is usually gonna have multi-layered P40 instead of monobasal and mucinous cells. Okay. So when you outline your tumors into your biphasic or your monophasic, you can then apply your knowledge of molecular to know what subspecific category these might be in, right? So pleomorphic adenomas have PLAG and HMGA2 gene rearrangements. Basal cell adenomas and basal cell adenocarcinomas have cylindroma, CYLD, and beta-catenin. We already said adenoid cystic has MIB or MIB-L1. Epithelial myeloepithelial carcinoma has HRAS mutation. Mucoep has mammal fusion. Nothing yet known for sclerosing microcystic. Your oncocytic neoplasms have no known genetics, but the rest mostly do. So myeloepithelial carcinoma, many of them have EWSR. Acinic has NR4A3. Secretory has ETV6 NTRK. Microsecretory has this MEF2C. Polymorphous and cribiform have various mutations and fusions in PRKD1 gene. Clear cell carcinoma has EWSR ATF1. Intraductal carcinoma tends to have RET fusions. Salivary duct carcinoma has like this conglomerate of PIK, P10 kind of variety. And then if you happen to encounter something like a MET, right, a metastatic squame or a metastatic basal, you might be looking for something like an ultraviolet mutation signature on your molecular testing or like a virus, okay? So most of these can be sorted out by morphology, immunos, and molecular. Okay, here's what they look like. So pleomorphic adenomas, right, conventional PLAG1 rearranged, biphasic with chondroid or chondromyxoid stroma, and likelihood of recurrence, especially if there are positive margins. There's this emerging entity of what is currently called an HMGA2 rearranged pleomorphic adenoma. But what I find odd about this tumor is that in most descriptions of it in the literature, it lacks a P40 layer. So how are we calling this pleomorphic adenoma when it does not fit the mold of a biphasic neoplasm? It's basically a monophasic P40 negative thing that people have called a PA because they didn't know what else to call it. And turns out it doesn't actually have a P40 layer, and it actually specifically has these HMGA2, usually WIF or WIF1 fusions. They have very, very high rates of recurrence, arguably even higher than our conventional pleomorphic adenomas. And so we are concerned that maybe this might not actually be a PA. So don't hold your breath, but hold out for maybe this kind of coming to be known differently as we understand better what these HMGA2 tumors are. But now on cytology, we've had a slew of them, right? Because we're sending all the basaloid ones for sequencing. So what happens, it pops up with a PLAG, it pops up with a MIB, or sometimes it pops up with an HMGA2. And now we've got a handful of HMGA2 fusions that are somewhere in this realm. Comments? So we'll see what this ends up being. It's bizarre. Basal cell adenoma, basal cell adenocarcinoma can mimic a cellular pleomorphic adenoma, can mimic an adenoid cystic, but the basal in its name is there for a reason. It secretes this eosinophilic basement membrane material, right, that you can see as either these little globules or sort of stromal bands. Like I said earlier, it very characteristically has this cellular spindled stroma in the background. And this cellular spindled stroma is diffusing strongly S100 positive, whereas the background the background epithelial cells are not, right? And if you were to do a P40, you'd see that it's positive in the abluminal cells. And if you were to do a beta-catenin, you'd see that many, not all, many of these cells have beta-catenin abnormally localized in the nucleus. That is indicative of a beta-catenin mutation. So you can often diagnose basal cell adenoma on core if you have this this conglomerate of stains.
Problem for us is
Yeah.
that these globules
Yes.
surrounded by blue cells.
Looks
get
like
really
adenoid cystic.
adenoid cystic,
Mhm.
and
Yeah.
that's a big problem.
Totally. So it's like if you have a cell block or a core, then arguably a beta-catenin could be useful. Okay, adenoid cystic, right? We all know the classic cribriform morphology, the tubular morphology, perineural invasion if you're lucky enough to see it, and MIB or MIB-L1 NFI fusion. So technically, we sort of call these predominantly tubular, predominantly cribriform, or predominantly solid, which implies a grade. But to be honest, they will treat them all as effectively high grade because that's how they tend to behave. Epimyoep is our other biphasic one. So I'm kind of focusing on the biphasic ones here, but we can, just for time's sake. Epimyoep has these like ducts that like pop or punctuate these like sheets of myoepithelial cells in the background, right? So you can see here how this is a little bit different from a pleomorphic adenoma, which is usually like one epithelial cell layer, one myoepithelial cell layer, and then that repeats over and over again with cartilage. This has kind of a different background of this very clear cytoplasm in these background sheets of myoepithelial cells, HRAS mutation. We really would love the IHC lab to validate the RAS immunostain because it's useful for epimyoep, it's useful for thyroid tumors. But so far, we haven't been able to get that on the board yet because there's a lot of other IHC in front of us, but we're trying. And last but not least, our favorite intraductal carcinoma. So technically, intraductal carcinomas should all have a P40 positive basal cell or myoepithelial cell layer that's present around all of these ducts. And in some of them, you can actually see, right, these little flattened cells at the edge. Those are the ones, right? You can see them on H&E, and you can appreciate them also on the IHC. The top IHC here is for S100. Some of your intraductal carcinomas, as we saw earlier, are S100 positive and mammoglobin positive and mimic secretory, right? Some of them of the apocrine morphology are S100, SOX10, mammoglobin negative. But they all have some variation of usually like a RET fusion, or in the rare case of oncocytic, some of them are BRAF V600 positive. But these are considered to be essentially in situ tumors because they're all bounded by this myoepithelial cell layer. However, some of our colleagues in head and neck pathology around the country have shown that in some cases the myoepithelial cells also harbor the RET fusion. So is this really an intraductal neoplasm? Or is this a biphasic neoplasm in which the second cell population is just very minimal? So to be determined, but on balance, if these really do have the in situ morphology, they are very indolent. They behave like in situ tumors, essentially. They do not metastasize. So we'll see. Here's another chart if you want it. Basically, it's the same thing that the other chart was saying, with the exception of we have additional immunostains and additional immunostains here. So you can look at that on your own. I haven't put in the monomorphic tumors in this lecture for time's sake, but you can check my other salivary gland lectures for those. Okay, questions? Yes.
You put a picture in that basal cell.
Mhm.
Are there like clinical things that you look at for your patient history to help at all?
No.
No.
Not the only, so there are two things of clinical history that you might want to know. Imaging wise, is the thing like circumscribed or infiltrative on imaging? Cause that might help you with a benign versus malignant differential. But otherwise, no, these are just mass forming lesions. The only other thing that has a specific clinical is Warthin. These patients are usually smokers. Warthin tumor, I think now we're gonna get into my soapbox. Warthin tumor, I think is a misnomer. Warthin tumor has never been shown to be neoplastic. It is polyclonal, it's never been shown to be monoclonal. If they, like X inactivation studies, like in females, right? So they have a heterogeneous X inactivation pattern. If it were a tumor, it should have a single one of the X's inactivated. So it should be Warthin lesion, right? It's not a tumor. But it pops up in smokers, it pops up unilaterally or bilaterally. That's really the only other clinical association. Even though the BCAs have the basal cell adenomas or basal cell adenocarcinomas can have the CYLD gene. Mostly these are sporadic. So the reason we put this here is because the morphology and the genetics is the same as the cylindroma of skin, but mostly patients with basal cell tumors, it's just sporadic. Yes.
So for the case set on psychology, I don't know what we ended up calling it, but maybe suggestive of secretory.
No, we
So-
call it secretary.
Oh, we did, okay,
Yeah.
I don't know what it was called, secret. So
I don't know.
if it's hemoglobin positive,
Yes.
in the future, and let's say it's the same thing, we have like just
Call it
scattered
salivary,
cells.
low-grade salivary type carcinoma.
Okay, that way it covers everything, got it, okay.
This is the exact reason why I generally refrain from subtyping my salivary carcinomas on any biopsy, because we've done this. We as a world fall into these traps, right? And so we've called biphasic things that are adenoid cystics, pleomorphic adenomas, and vice versa, and secretories and intraductals, right? And so low-grade salivary carcinoma, or low-grade salivary neoplasm. However, there is no benign neoplasm that's like is strongly hemoglobin positive, right? It's a carcinoma. So low-grade salivary carcinoma.
I mean, if you ask me, unless you can pretty much diagnose few things in the salivary gland as specific. Like if you have very, very classic pleomorphic adenoma, you can say pleomorphic adenoma. If you have adenoid cystic that you think it's very, very classic, you can say adenoid cystic. But everything else is floating somewhere. Therefore, if you ask me, I would send everything for fusion.
You should send everything both for fusion and DNA, because
Yeah,
the other half, no, I'm just kidding. The other half of them have few mutations.
I understand.
I'm just
would,
kidding.
I would love it. I don't know what Dr. Arbor would say about that.
Yeah.
But at
Totally.
least with fusions, you can actually figure out most of it.
More, yeah. So we've, again, in the last, I don't know, 10 years, we've come a long way in subcategorizing salivary neoplasms. Because it used to be pleomorphic adenoma, monomorphic adenoma, and carcinoma, right? There really is that, so we've come a long way. What's the television commercial? We've come a long way, baby. Is that, no? Was that for a cigarette commercial back in the 80s that we can't advertise cigarettes online on TV. Okay, more questions. All right. 10 minutes, my favorite organ. So in the WHO 5th edition, this is all the thyroid things in the WHO. We're kind of gonna focus in the follicular cell derived ones, because that's where the problems tend to occur. And we'll start with the carcinomas. So I'm gonna start with genetics, because I think now that we're doing interpace, whatever it's called, Thyroseq, Afirma, whatever, on all of your thyroid indeterminate FNAs. All of these genetics are just coming to the forefront. And so to be able to understand what they mean, I'm just gonna start with genetics. So a lot of this started from the TCGA study, which came out in 2014. I have this paper on hand. If I have no idea what kind of mutation or fusion I'm looking at, it was probably found in this paper. So they tested about 500 PTCs at the time, which now we know what that means. But when they looked at these 500 PTCs, they sorted them into two groups. One were the BRAF V600E-like, and one are the RAS-like, right? The BRAF V600E-like have a gene expression profile, which is this blue line, that is very, very similar to our conventional BRAF V600E mutated papillary carcinomas. The RAS-like have a gene expression profile here in red, right, that is very similar to our follicular neoplasms, right, like follicular adenoma, follicular carcinoma, quote unquote follicular variant of papillary, all right? We'll see where that goes in a minute. But as you can see, they are mutually exclusive. They basically come to a pivot point and they turn, right? And they do not overlap. So the BRAF neoplasms and the RAS neoplasms are completely biologically different. You can see that the BRAF-like neoplasms are those that are truly BRAF V600E positive, those that have BRAF variant fusions, and those that have things like RET fusions or even ALK fusions, which aren't on this table, right? But they're to the left of this line. They have papillary growth often, they have conventional nuclei, they go to lymph nodes, and they generally have good prognosis. They're radioactive iodine sensitive. The ones on the right side of this line, the RAS-like, are those that have the true HN or KRAS mutations, right? Or BRAF other. What is BRAF other? So BRAF other is a BRAF point mutation that is non-V600E. The most common is K601E. So when someone says it has a BRAF mutation, ask which one? Is it V600E or is it K601E or is it a different variant yet? Those are RAS-like, which will be important in a minute. There's also the Pax8 PPAR gamma fusions, and now the recently discovered Theta IGF fusions. Those are follicular neoplasm-like. These tend to not invade lymph nodes. These tend to, if they're going to invade, right, they're going to invade blood vessels. They're going to go to distant visceral sites and have variable prognosis. In the absence of invasion, these are good prognoses. They're basically benign. Other genetics include the NTRK fusions. So you can see here how the NTRK fusions are probably one of these tumors that is very close, right, to the inflection point. And in terms of the gene expression profile, actually straddles the inflection point. And morphologically, that is also the case. It tends to have both follicular and papillary growth. It tends to have nuclear features that are mild and not as robust as our conventional papillaries, right? But they're invasive. They go to lymph nodes and they kind of behave like PTCs, even though the nuclei don't always look like PTC. All right. So I call these the straddlers, right? They straddle the line between papillary and follicular. Then there's the other mutations, things like TERT promoter or TP53. Those tend to be accumulated on top of one of the other drivers, and they usually, but not always, portend high-grade behavior. So if you see a high-grade carcinoma, which we'll talk about in a minute, generally it's going to have a P53 or TERT. If you see a P53 or a TERT, that doesn't necessarily mean it's a high-grade carcinoma, right? So there have been reports of completely benign macrofollicular, like follicular nodular disease, adenomatous nodule type things that have isolated TERT promoter mutations and do nothing, right? So one does not equal one. Okay. Additional studies have come out now outside of the TCGA specifically on things like oncocytic thyroid neoplasms or formerly Hurthle cell. You can see by this map that the oncocytics over here in blue have a completely different gene map than the papillaries and the folliculars. And on genetics, they tend to have mitochondrial DNA mutations and copy number alterations with occasional RAS-like mutations. So if you have an FNA that's oncocytic and it comes back with a copy number alteration that kind of fits, right, with the morphology, that's yet its own unique thing. Make sense? All right. So I'm gonna dive a little bit into some of these rarer tumors now that are not part of this framework. One of them is hyalinizing trabecular tumor. So this is basically a circumscribed, non-invasive neoplasm that is, as its name suggests, grows completely in trabeculae without really good follicles, without really good papillae. But the nuclei are nasty. There are inclusions, there are wrinkles, there are clearings, there's grooves, all the bad things that we think about with PTC, right? But it's not invasive. It specifically grows in trabeculae. It often has stromal hyalinization, and guess what? It has its own fusion, which is GLIS-PAX8. So now we know that this is in fact an entity in and of itself. It really does not metastasize. It's maybe just benign. It's maybe just benign. I don't know, but because we're not sure, it's in this so-called low risk neoplasm category, meaning I'm not calling it benign, but I'm not calling it malignant. I'm calling it, please do not harm the patient, just watch them and they'll probably be fine, right? Don't treat them, just watch them.
Long time ago,
Mhm.
I was told on FNA when I see that almost every cell has intranuclear inclusion, not to call it PTC. Because PTC usually we have to hunt for intranuclear inclusions as opposed to like every cell has intranuclear inclusion. Therefore, that advice was given to me when I was training in cytology. Maybe that's one hint that you can have regarding this neoplasm.
Good point.
So probably call it AUS, it's in molecular.
Yeah, exactly.
I'm traumatized. I specifically remember having one of these on my boards exam, and I couldn't figure out whether it was a paraganglioma or a PTC or a hyalinizing trabecular tumor. So if that's in your differential, that's correct. It's this. It's this. Okay. The other low-risk neoplasm, non-benign, non-malignant, is NIFT-P, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which, on balance, is a RAS-driven neoplasm, basically a follicular adenoma with funny nuclei. So I'm gonna go over this in a minute, but on low power, does anybody want to call this carcinoma? No, right? It's completely circumscribed. It's arguably made of some small and then some larger follicles. It has a nice border, all right? But on higher power, you start to see nuclear overlap, clearing, grooves, and wrinkling, right? And so this is why on FNA, these could be considered to resemble PTC. And this is why for decades, these were called PTC, right, because of these nuclei. But 10 years ago, almost, 9 years ago, people discovered that if these things are circumscribed and not invasive, if these things don't have BRAF mutations, these things behave benignly, they don't metastasize, and they have RAS mutations. So the only thing that makes them different from a follicular adenoma, right, is the fact that they have these nuclei. So we now minimize the relevance of nuclei, and we call these quote unquote NIFT-Ps. We can talk for hours about it, but this is the general concept. It's 1 o'clock, so I'll move on. So NIFT-P, basically, in the past, follicular variant of papillary carcinoma was either, quote unquote infiltrative and it looked like a classic PTC with BRAF, or circumscribed and it looked like a follicular neoplasm with RAS, right? It is the non-invasive, circumscribed, encapsulated follicular variant of PTC that came out as a NIFT-P. And these are moving and these are moving. If something that's called a NIFT-P invades, it is now still called the invasive encapsulated follicular variant of papillary in accordance with the antiquated terminology that this was the non-invasive encapsulated follicular variant of papillary. Does this make sense, or am I being more confusing? Okay, so we've gotten the word follicular variant out of this one, but we still have it in this one. But all of these are RAS driven. All of these invade vessels and travel hematogenously, okay? There is a paper that was recently accepted that is calling for a revision of nomenclature for this tumor because it's not papillary. It's follicular carcinoma with weird nuclei, and this is follicular adenoma with weird nuclei. So that's my perception, as you can see here. So now we have this clean line of BRAF-like versus RAS-like nuclei that are funny on both sides.
The whole point of all of this
Yes.
is that if you are seeing microfollicles and they have a typical nuclei with no internuclear inclusions
And no papillae.
and no papillae, I mean, we rarely see, but if it's microfollicular with a typical nuclei and no internuclear inclusions, you shouldn't be even going into the suspicious for PTC or PTC, none of that. You should just say AUS, send it for molecular. Molecular will then decide, is it RAS mutated, which is, in most cases, it is. And then they should know that these are actually not PTCs in any kind of sense.
Yeah.
Therefore, microfollicular architecture with a typical nuclei and no internuclear inclusion. Do not call it anything suspicious for PTC or PTC, because that's not PTC.
Phenomenal.
Okay.
I wish everyone practiced like that.
Yeah.
Okay. And in the last couple minutes, I do want to talk about the high-grade carcinomas because we have to think about them. And if you don't think about them, you won't diagnose them. So the high-grade carcinomas are those that are either anaplastic or not anaplastic. The line being anaplastic doesn't look like thyroid. You take a field of it, you're like, I don't freaking know. It could look like squamous cell carcinoma, it could look like sarcoma, it could look like a necrotic garbage, right? But the high-grade non-anaplastic morphologically still look like thyroid, okay? So the high-grade non-anaplastic are defined by the presence of either increased mitoses or necrosis. So usually they start as either a papillary or a follicular or an oncocytic. They can develop some secondary hit like a like a P53 or a TERT promoter, or they can just go straight to usually they just go straight to anaplastic without this intermediary, or they go to the here and then they stop here. But you can see how it can go in any of these directions. But there's usually some precursor. The high-grade non-anaplastics retain thyroid differentiation markers like PAX8 TTF1. The anaplastics often lose everything except some of them keep PAX8. Many of them keep PAX8 and that's all, maybe keratin, right? But anaplastic looks spindled, epithelioid, squamous, highly pleomorphic, giant cell rich, right? Whereas the high grades on the left do not have that morphology. But if you start seeing things on your biopsy, right, that are like grungy, necrotic, mitotically active, that's when we want to start thinking about high grade. And so high grade has two subtypes, being the conventional poorly differentiated thyroid carcinoma that was described back in like 2007 in the mountains of Italy, and all of these iodine deficient people. And so they basically had these RAS-driven cancers that were very solid, that didn't have papillary nuclei because they're not papillary, but they had mitosis and necrosis, and these were called poorly diff. However, up until a couple years ago, we were kind of missing this bucket. We were missing this bucket of variable growth patterns, but the presence of mitoses and or necrosis. They were just called, papillary carcinoma, follicular carcinoma, whatever. Then we realized if they do have increased mitoses or necrosis, they actually behave similarly badly, right? So kind of intermediate between the well diff and the anaplastic. And so if you remember anything from this slide, remember that the presence of mitoses and or necrosis is what defines a high-grade thyroid carcinoma. All the rest will fall into place. So high-grade PTC on the left still has some solid growth, but doesn't have to. It still has some follicle growth. High-grade FTC has microfollicular growth and invasion. Poorly diff is now essentially completely solid with invasion. What do they all have? PTC, of course, still has the bad nuclei, but it has necrosis. FTC doesn't really have solid growth, but it has mitoses and necrosis. And then poorly diff has solid growth and has mitoses and necrosis, right? So that's how we kind of sort them out. But they all should have mitoses or necrosis. Necrosis being usually punctate, surrounded by viable tumor, right? Punctate surrounded by viable tumor without fibrosis, hemorrhage, hemosiderin, histiocytes that indicate that this was a needle trap, right? So this is naive de novo necrosis. I just wanted to remind you at the very end that anaplastic carcinomas can look like anything, but they often can look squamous. And so if you see something that looks like a squamous cell carcinoma in the neck or mediastinum, it could be anaplastic thyroid. We had a couple of them, a few before Spencer graduated, that were, one was in the neck, one was in the mediastinum, and it was like, is this thymic? Like, is this a thymic carcinoma? Because it's in the mediastinum. Nope, it's BRAF positive, it's anaplastic thyroid in the mediastinum, right? So just keep a broad net and throw your BRAF. If it's BRAF positive, it's squamous anaplastic. Hands there, it just is, okay? Not all anaplastics have BRAF drivers though, right? Some don't. But if it does, it's diagnostic. If it doesn't, then you might have to still do the genetic testing to see what else it might have. But the reason the clinical team is so on edge about BRAF is because they have a magic bullet, right? They have the brafenib, they have a BRAF inhibitor. They will give it yesterday to the patient if they could, right? Because it works so quickly and it is very effective at cleaning up the anaplastic component. We've seen anaplastics coming from a BRAF PTC that they treat with dabrafenib, they resect, the anaplastic component is gone, right? All you're left with is the welded PTC. So it's a really, really, really good treatment for these patients that otherwise have a really poor prognosis. I don't know how well BRAF works on cell blocks.
One of the things that we were trying to validate is nothing is validated, but we are still lagging good understanding how this thing works.
Right. But it works great on core. So, okay, that's it. We've seen now the differences between cats and lions and wolves and dogs. That is all. Do you remember this AI? Remember this AI model that was like trained to predict monkeys versus dogs? And it wasn't actually seeing the dog, it was seeing the snow. So anything with the snow was called a wolf. But then it mispredicted this husky as a wolf because it thought no. That's all I want to say. Okay, thanks.
Thank you. Thanks for the.
You're welcome.
Gotta try to find some top of yours.